Hello, everyone. Welcome to the Preemie Health Talks. We are restarting this talk with Dr. Banihani because we had audio issues. I am Rudaina Banihani, Executive Director of the Canadian Premature Babies Foundation and your host for this event. The Preemie Health Talks is the first of two international live series that CPBF is hosting 2020 in recognition of World Prematurity Day. And next month, I'll be hosting Preemie Power Week, which is the same idea of bringing a live session with experts and parents from all over the world, and all the information is already on our website. These educational sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANS, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With the Preemie Health Talks and the Preemie Power Week, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world, which is extremely valuable to help us care for families and their babies. I want to thank AbbVie for the unrestricted educational grant, Pampers, and all our team at CPBF who worked really hard to make this week possible. And today we had already two sessions, one with Dr. Paige Church from Sunnybrook and Rebecca Pierce, a teacher, a parent, a teacher, and also a researcher. At those talks that will be available on our website next week. And right now we are going to talk about neonatal follow-up in time of COVID. With the declaration of pandemic by the World Health Organization in March 2020, many neonatal follow-up clinics shifted to virtual visits. This talk will review one approach to follow up in time of COVID, with increasing attendance through video visits, video instructions, and enhanced communication with families. Dr. Banihani, who is joining me here now, is an assistant professor with the Department of Pediatrics in the Faculty of Medicine at the University of Toronto, and holds an academic position in both the Division of Neonatology and Developmental Pediatrics in the university. She holds a staff position in the Department of Newborn and Developmental Pediatrics at Sunnybrook Health Science Center, providing clinical care in the NICU and neonatal follow-up clinic. Dr. Banihani has a long-standing interest clinically and academically on understanding, evaluating, and optimizing developmental outcomes of premature infants, as well as children with brain injuries, brain malformations, and genetic syndromes that are identified in neonatal period. Dr. Banihani, thank you so much for joining us here today. I'm so happy that we could fix our audio and now we are back live. Please share your screen with us and your presentation. And if you are joining us now, feel free to send your questions and comments on the link below, and we'll address them at the end of her presentation.
Thank you very much for having me, and I'm really sorry for the technical internet issues. I'm glad that I'm at work and near Paige office. So I'll share my screen. Okay. You guys see it now?
Yes, if you can use your one slide, like a bigger view would be great, not the speaker view.
No, sorry. Don't know where is that.
If you go on the PowerPoint, you go top on slideshow.
That's what I did. But again, it's Paige computer, so I'm not sure where I am. Sorry.
It's okay. You can go with that.
Can I go with that?
Yeah. If you want to go on top of that, you see slideshow.
Oh yes, yes.
If you go on slideshow.
This is what happened when I do slideshow.
No, the other side. You can go back on your PowerPoint. And there is, next to animations, you have slideshow right there. And there is a from current slide or from beginning, which is the first one.
See, it's the same.
Okay, let's go with it.
Okay.
We are live. It just happens. Technology happens, problems, tech issues, but let's go with it.
Okay. So, hi, everyone. I am going to basically, this talk is a continuation of Dr. Church's talk with regarding what we do in terms of like optimizing outcomes. I'm going to be talking about the neonatal follow-up, where we at, where we were, where we at now, and how we're going to move forward. The work I'm presenting, it's not my individual work, it's the incredible team that I work with. I have nothing to disclose. And the objective of this talk really is to talk about overall what's the purpose of the neonatal follow-up, what's the needs that push us for change in the redesign of our clinic here at Sunnybrook, what's the clinic design based on, and what was the impact of COVID in our clinic design, what did we learn of being virtual, and how we're going to move forward. So historically, neonatal follow-up was created to evaluate the outcome of infant admitted to the NICU. And like preterm kids are not the only infant admitted to the NICU, but they're usually the majority of the NICU and NICU graduate. So the data that came when initially neonatal follow-up created, it was to basically collect data that will tell us about what is the survival of the preterm population graduating from the NICUs. Also to identify conditions that associated with significant lifelong challenges for the children and their families who graduate from the NICU, which help kind of modifying a lot of the care that we do in both high obstetric OB as well as the NICU ward. It's also at the level of the NICU, it help us and our colleague to basically change a lot of like care that we provide, the face of the care we provide in the NICU, as well as to modify the NICU environment. Over the years, all these data helped us to start offering support to children lower in gestational age. And now we're offering support for infant born at 22 weeks of gestation and above. And moving forward with the neonatal follow-up world, we start having now more data that emerging that looks at the functional outcome of children at a different stage in their lives later on, childhood, school, and adulthood. When we come to the outcomes of prematurity, we know in the literature that this is where like the most focus of the literature is in their early aspect of life, that they classified and describe the outcomes in the literature as different aspects according to the degree of functional challenges. Often the significant challenges of care associated with disabilities are the primary outcome, or the one that like basically like show themselves or identify early in life, and they call them also the primary outcome, which would include motor challenges in the like under the CP, cerebral palsy, intellectual disability, and neurosensory impairment. These outcomes are detected early, usually prior to the age of 3. However, they have a long-term impact on the family and their children. This is where majority of the neonatal follow-up traditionally stop at this stage, because that was the focus at the beginning. However, there's other outcome that is being described in the literature of being subtle or discrete, minor, but they have a considerable effect on the school challenges as well as for the long-term challenges. And then under the umbrella, what we call the phenotypical behavior phenotype prematurity, which kind of like our clinic is one of the early like clinics that describe these and basically focus on these outcomes. So that with these discrepancy in outcome, we know that there's a broad spectrum of neurodevelopmental outcomes for our graduate. The outcomes are usually dependent on the underlying etiology, the pattern and severity of the brain injury. However, we also know from our work in follow-up that genetics, postnatal variables such as socioeconomic status, environmental exposure, parental education, and parental stress all also affect these long-term outcomes, and it's an important player into the function of our children. So there was a push to move forward. instead of doing the surveillance to collect data and identify, we need to take these surveillance data to basically move toward identification to help with optimizing an early intervention. So the stakeholder in like basically child development as well as in a neonatal follow-up word start saying like we need to move forward with what we're doing. So, but we have to involve what about parents? We have to involve them in our goals of surveillance, what actually they want. We need to provide parents with richer outcome data to the families. So then from amazing paper from Katrina Sterb, like basically said that we need to look at our children beyond their gestational age. And we need to, and she has a very nice quote, which I put there, that we understand that clinicians need to examine outcome and classify children. They can be serious, moderate, mild disability, or maybe classified as typical. These categories are created by physicians. If we were asked to classify our children are disabled and not disabled, then doctors would have different categories. And also, who decide that hyperactivity is in the mild category or mild disability compared with cerebral palsy is a major one. So we have to listen to the main player in these children's lives, which is their parent. And so we said, okay, where, when, and where to start. As we consider that, that we know far and most that from Hickensman's work that the earlier you start, and of any intervention, the most economic. So then how this was transferred to our program. So we took all these and we said, okay, in Sunnybrook, we need to basically adopt these changes to fit the needs of everybody. So the purpose of like the redesign was actually to implement changes in our clinic that is incorporate and reflective of the neonatal ward as well as the developmental pediatric ward. And the key to that is the F word of child development that's created by the CANN Child team led by Dr. Peter Rosenbaum, which looks at most 6 categories, which is family, friends, fun and fitness, to basically look at the future and look at function as the major outcome that we want to look at. So then we came and say, follow-up alone cannot do this. We have to go and start early, and we have to start as a program where we start when mothers are admitted to the high risk with a chances to have a preterm labor. So we start a multiple touch point that start at high risk, at the delivery, in the NICU, and then comes to follow-up. But we said we want to have even an earlier presence of our philosophy, which comes even in the NICU, where it comes in like too many forms: social rounds, milk and cookies, neonatal consult early on, and boost that Dr. Church talked about. So then really what's our goal at the end? It's to empower parents to know their children, believe in their ability to able to support and advocate, regardless what the outcome is. You can call it whatever you want to call it. So then that has to be reflected by the team. It cannot be only physicians, because it has to be a multidisciplinary team that take care of these family. So in our program, we do have, we are 2 physicians with the neonatology and developmental pediatric training. The nurses that work in the unit actually are nurses who worked in the unit. They've been in charge in the unit, they work in the community, and they're now with us in the clinic. We have an amazing team of therapy with like amazing expertise. And we do have the admin support that basically keep us in our place and keep us on like line. And one, we're very grateful to them. So then to anchor these changes in the visit schedule and how we follow the kids, we have to basically adopt a key developmental concept that's called Touchpoints. And when we come to Touchpoint, it's created by, or like first described by Dr. Brazelton, and basically a godfather in development and of the children and child development. He described these Touchpoint as a temporary period of developmental disorganization for the child and the family that is followed by reorganization and the emergence of a new development. So you have like, it's become kind, because how much we know that development is complex, we need dynamic process, we need to take these Touchpoints. So that would help us with early identification and intervention transition outcome. Still, we are traditional follow-up. These Touchpoint offers a mean to join the family system of care as a provider, and then that will give us opportunity to build the child and the family toolbox. That's the whole goal. It's to really empower the family and the child. So then, why Touchpoint? A lot of people will ask, why this? Because the mechanism of these Touchpoints effects include the family-provider relationship, which at the end will result in parental competence, confidence, and have a positive power of development during these developmental crises. When these Touchpoints happen, usually the parent are worried about either their child development or they're worried about their effectiveness and capacity as a parent. So when these happen, the team will provide a very good approach and guidance to the family to absorb these stress moments and to basically interfere when it's the most emotional availability, and continue to interfere with emotional availability and help the family. So how that's look like? So in the first year of life, the Touchpoints, it's range. So when we start as early as 1 week, or even we start from Boost when Dr. Church talked about it. These are the Touchpoint, and you guys can look at it during, like when I share the slides with you. We still have the traditional, follow-up philosophy embedded within these Touchpoints. We still look into the medical stuff in terms of feeding, growing, family well-being, early motor skill, screening for visual and hearing, early signs of motor impairment. And the whole goal is to connect with services and empower families early. Coming to the second year of life, we also look into these, and these are the Touchpoint where we see the kids. Again, early identification is there, including autism spectrum disorder. Community support is always there. And moving after the 3 years, it's school readiness. I want to get you ready for school, which the parent usually think it's not gonna come, it's too far, but it's moved so quickly. But then when we come to school, we were like, okay, there's something missing about the school children that is usually being addressed in the previous design. We noticed that in the data, when we looked at the data with the school outcome, the data said that the knowledge in education sector is weak, at best for outcome of prematurity and how they impact the school setting. Not only that, we also know that being said that the actual educator and the care provider at school, they don't know much about our children. They basically don't know about our children or about our family. So with the work of Dr. Church and the team, basically we reach out for educator. Kind of, it's like at a prevention level, it was not much feasible because of the difference between the educational board and how the school are functioning. But we found that the teacher want to know more. They want to be educated. They want to know about our children. So we said, okay, we're gonna put our Touchpoint, but we're gonna basically reach out for them to bring them into the table. And we do with our collaboration with them, have their insight, so we can work together to basically help the function of the kids. So we change our visit and design to address these things. So we start doing the kindergarten visit and the school age visit, involve the teacher, get the teacher input. It's not what Rudaina Banihani said. It's not what the parents are saying. It's actually the teacher, so they listen to us. We have early identification of learning barrier. We really study from developmental, the behavioral phenotype of our preterm. We educated the teacher, and we get academic support to the teacher as well as to our children. And it's really the goal at the end, when we discharging our kids after this to entering the real world, we give them the right tools. So then the family can really go and fly with the tools that we provided them as we move along. So then we cannot work alone to do this. We have to collaborate with what's going on who's in the circle of care of our children. It's a big circle. So there is a lot, like the primary care provider, the community services, the family, the school. We need to work with respect, communication, and partnership. And the goal, we start too close to the family at the beginning, and the goal for us to move out in that circle after that, and then basically stay in the background because we provided the family with the right tools and also the schools. To do this, in February 2020, when we decided this is what we're gonna launch, we didn't do that, okay, to be efficient in our work and to be collaborate better, we need to be efficient in our database, in also our communication, our letter. We used to type our letters. Now we have an electronic system that we are using, which really changed our life. And then we're getting ready to go to March break because we need to have we did all the job, we did all the work, and March comes and oops, it's COVID. We're not going anywhere. Not only that, all clinical care that was deemed non-essential was canceled. And that's including our clinic and also clinic across the world. We kind of went on a freak out mode, but we said, we have to work immediately. We cannot shut down. This is where our family need us the most, and we have to move. And I think the platform that we created before and the electronic charting make us a bit confident that we can start immediately. So what we did, we did not cancel any patient. We transitioned to a virtual platform in an interprofessional manner. We immediately reached the hospital, and they were amazing that they created a video conference platform that basically match as much as we can most of the hospital privacy and patient privacy. We also created consent that apply to the satisfactory regulatory basically colleges for all the different disciplinary team that works with us. At the beginning, we kind of on a panic mode. We do more frequent visit because we moved from a totally in-person, I need to touch you, I need to see you, I need to talk to you, and the parent as well not there, to really more frequent, to learn the new tool and to learn to basically overcome some of the platform limitation that being via Zoom. So then how it look like? We have all the redesign, we know what we want, but how it look like virtually. We continue taking the same touch point. We did not change that. But then with the touch point, there's certain things, assessment, or basically needs that need to be done more intense than just seeing you on Zoom, like the feeding assessment. So we start doing virtual feeding support, medically and therapy, thanks to our amazing therapist who been amazing creative. Infant growth. So what can we do? We need to know how our kids are growing, especially in the first kind of 3-4 months in life going out from the NICU. So parents providing the weight. Some family were creative. We have parent scale, they weigh themselves, they weigh the baby, and we get a weight. We purchase scales. We basically, family who doesn't have a weight, we purchase scale and we send them to the families. And we also involve heavily the caregiver provider in the community to give us insight about the weights as well. And the frequency of the visit was really more intense to really capture that feeding as well as growth. Developmental surveillance, we continue doing them with using certain assessment that we created that actually we're lucky they were visual, video-based tools, like the general movement assessment, work perfectly with Zoom. So we created kind of a video instruction to the families how to help us with the assessment, how we're gonna put it in and upload it into a secure link. And that's like by April, we're flying and we know exactly how to use it, and our families are very good. What about overall developmental assessment? Everybody knows that we used to do the Bailey. We used to do a lot of like hands-on assessment. So between 8 months and 48 months, we really now depend heavily on our skill, being a neonatologist and developmental pediatrician. So we created an interview sheets that basically touch everything in terms of development, ask the right question, medically and developmentally. We did a lot of informal observation, sit down in the camera and just observe the child torturing us and the parent and the Zoom and all the thing and see what they're doing in their own environment. And we also then adapt a lot of the developmental questionnaire that is capturing a lot of these developmental question and touch point, like the age and stages and the survey of well-being of young children, the SWIC. School age, we did the same, and we adapted a school questionnaire that the parent can also give us an academic insight if we could not get it from the teacher, we're so busy with virtual and what's going on. So what else? We need more tools. From the feedback that we had already obtained in 2019, when we start doing the redesign, we have a really like a push from the families that we really need to move. We're busy. There is an online revolution, and we really need to go into more online to have attendance. So at that time, we start having just starting the Facebook start there in 2019. We have a website that's supposed to be targeted for professional and as well for parent. And we start doing videos for all the motor-based coaching and the homework that our therapists do in the clinic. We did videos and we start doing a nutritional handouts. But then with COVID, some of the stuff still we need to add. So we created a virtual mental health support list per region that we could provide to the family. We also created a COVID-19 governmental funding support with link, and we list it, and we also study the support, and so we can support the families. The workshop we used to do before, we took handout from this workshop, the sleeping workshop, the toileting, and the handwriting. We created handouts that we could share with the family to read later when they need as their reference. So Facebook we become savvy in that, Instagram, and then we said, okay, family needs more support with this hard time. So we start doing a weekly program of virtual drop-in session with clinic members, parents, and social support and information session. What's the update of COVID? What's going on? What does that mean? Numbers increasing, number decreasing, mask, no mask. So we start doing that, and it's just sitting down for an hour, and anybody is welcome to come and let's answer the questions. And then Paige and I become, okay, we have to be kind of creative. I don't like videos, I don't like anything, but I have to do it with Paige. Was funny. We did Ask the Doctor session on Instagram. So we did that. We basically have a theme. The parent will send a question, and then Paige and I and anybody from the team will answer questions. Then we said, okay, we need more. The community services are not coming as fast as what we want. So what else we need? So our team were amazing. So we start doing an online speech and language workshop. We implement the More Than Word workshop. We are now running our second one, and we're going now to do, we're basically recruiting for the third one in the winter, which like really went successfully and amazing. And also we start relying more on our community partnership. So once the community partnership catch up with Zoom, we start relying on them more to be also in the home to give us more input of what's going on. And also some of them start doing like more going even a social distance and meeting the family outside. And we start really relying them heavily to give us some of the inputs that we cannot have. Okay, I'm sure everybody will say, what did you do in this special situation? It was not like really just smooth and everything was fine. We did, and we had special situation that we have to do. What if we really, even with the feeding and growth, we still have concerns? And we know that it's a very critical period in our tiny one when they get out from the NICU, between their like first week at home to the 4 weeks, how feeding is going. So we offer more frequent visits, lots of coaching and therapy session. We like sometimes we even do it twice a week, Monday and Friday, how things are going. And it might be just 10 minutes, how feeding going is the recommendation we give make sense? Yes or no? And we follow it up in 2 or 3 days. We also partnership with our community provider. So we reach out for the primary care physicians and for the pediatrician. We do have concern. This is what we're doing. We need to be all together at the same level. So with the kids who are and the family who are struggling with feeding and growth, we made a joint visit. And that's the beauty about virtual and Zoom with the pediatrician. They might go to the pediatric or the family doctor office. We Zoom in and we see the assessment while they are in their primary care provider office, which really works beautiful and make us all at the same page, and also make it consistent and decrease the conflict or the too many messages and too many cooks to the family. And also then if that is not working, we reach out for the community feeding clinic and the community feeding OTs or support that they can go to the home and support the family. And so far this is working. What if we have a language barrier? In a way, our clinic, we don't have a postal code. So we have a broad family, like a broad range where we're following, and we do have a new immigrant. We have family who does not know how to use Zoom. We have family does not like the language. So what we could do? So we basically reach out for the hospital. We use the certified language translator by the hospital to join the visit. We increase the duration of the visit when we have language barrier to basically give time for the parent to the translator, for the parent to ask question. I usually took slower. I learned to do that. And in phase 2, we started bringing these family in person with the translator. And when the in-person visit has a lot of forms and basically vision, like we saw them in the parking lot. Now our parking worker and like all the downstairs in Sunnybrook know us. We have a spot downstairs that is called the clinic spot. We saw kids in the back of the family car in the green space around the hospital or the park around the family. We went to families that parks near to them. What if we have developmental concerns or a formal diagnosis need to be given? So in a way, what we found that our kids are divided into 2 groups. We have a group that we have already seen them prior to March 2020. There is concern being identified and discussed with the family in person. And then March came. These were kind of a bit easy because we already implanted the seed. So we did the virtual confirmation or the concern and or the diagnosis in a virtual platform. And we basically followed with multiple appointments after that to support that, like basically the concern or the diagnosis. We have a bit challenge with the kids that we identify challenges while we are on the Zoom platform. And this has never been discussed with the family before. It's in Zoom, it's a bit limited. So in a way, we didn't know at the beginning how to approach these. So what we did, we offered more frequent visit, and the visit were in a therapy coaching as well as consultation. We have we did a lot of consultation also from our team reaching out for the community services. We did, and by these coaching services as well as consultation, the kind of the parent would be on board with us with the concern and what we're seeing. And then we lastly brought them in person to basically confirm our concerns or basically rule it out. And that also, again, is it the park near the family home? Is it outside the hospital? Or it's an inside a clinic visit where we look like astronauts and we have all the stuff wearing and we look like the children did not care at all, which is very nice. And then we still going on with confirming diagnosis and connecting with services. And we do a lot of follow-up to make sure that the family are on board with the diagnosis, how they're doing after it, and how they're doing. And we immediately reach out for the care provider to bring them into the loop when these things happen. So primary assessment and result of what we have. So we like, again, looking at it since March, our show rate increased. We have an 81% show rate in 2019. Now it is, by April 2020, it's 91%. Our social media presence increased. Our daily posts have resulted in an increase in membership, 55% in the 2 months from February to March 31st. A review of the post relieved up to 80% of membership reviewing of the post at any given time. And Instagram membership reached 135 members in a matter of weeks. And the average visit number increased by 40% to more than 200 clinic visits per month. Workshop attendance improved dramatically. And to be honest, this one we have no idea, is it really the virtual media platform, or the family are more available because of the COVID restrictions? And the kind of like the busy household slow down, that they do have time to attend our workshops. And that needs to be addressed differently. So then moving forward, future of the follow-up. We are in a virtual healthcare revolution. I don't think where we are now, especially that it's capturing a very high demographic like area and like more reaching out for more families, we're gonna go back to that totally in person. We're thinking of a hybrid model of in-person and a virtual assessment will be the mainstream channel for the future follow-up at Sunnybrook. We know that the follow-up rate will increase. We have improving access, quality, and efficiency of the service we provide. The cost, it would reduce travel, parking, and the meals, data, like a lot of other things is there. And we're actually in the environment of the child and the family, which they really like. And also more engagement of the community provider and community services. But till now, we need more. We need to ask the parent, is that what they think about it? What else we should add? We also need to evaluate our virtual clinic model and decide where is in-person visit should happen based on the touch point and the assessment tool that will keep us still on the radar of the national surveillance that we need to contribute with data. And that's it. Wow. So that's us. This is the team. We are the Incredibles with all of us. And I'm ready for questions.
Absolutely. You can stop sharing your screen so everybody can see you. Dr. Banihani, what a great presentation. And I really want to congratulate you and the whole team at Sunnybrook for really stepping up right in the beginning, from the get-go of the pandemic. And as a mother who's been in the system with a complex child for 80 years, I applaud you, because I know how hard it is to make changes in the system, how hard it is to go virtual, to have a virtual appointment. So all my kudos to you and your team. It's amazing. So
it's again, like the team works so hard.
So questions for you. You already mentioned that, but the benefits from a virtual appointment with families in follow-up, besides the distance that they have to travel, those are the things that we kind of know, but what have you seen as a benefit for a family, the feedback we got so far?
I found one of the main things that I'm in your home. I am like really like we're basically, you're in your home, your environment. I'm seeing what's going on. It's kind of like more personal. I'm seeing the child. I'm seeing exactly what you're looking in. We see the children even involved with us in a more different way, because they, especially the older one, they're so excited to see us. A lot of like they're not coming to a doctor appointment, the anxiety coming to the hospital. A lot of family don't like to come back to the NICU or come to the environment. They do have a stress and also maybe PTSD, trauma involved with being in the NICU for a long time. I'm sure they want to have their kids and run. Having that, make it a bit more approachable. We see the family. Again, at the beginning, they were not sure to do what about this. We were not sure, but we found it's more informative and personal, and a lot of family actually liked it.
Okay, because I always saw that when my son was under, many eyes, he wouldn't do anything. But once he was home and I made videos and I showed the follow-up, oh, he can do that, just not here.
Yes, exactly. Exactly. And a lot of time that like you will say, like, look what he's doing, and you see it, like the child first, the mom like we're talking in the background, we're looking at the child playing or doing like anything, sleeping in the environment, like even that informal observation that the mom is talking and we're talking and we're all checking and we're doing all the stuff in the background in the child environment, which is really amazing.
We have a comment here from a mother, I believe, from Sunnybrook, Kate. Thank you, Dr. Banihani. We will never forget how hard you worked for Jack when he was very sick. So we love to see those comments coming back from parents, right? Because sometimes you don't see them that often and you don't know how, well they are growing, and this is great feedback.
And I'll tell you something with Zoom, it's so amazing. You see them and you can see them growing, like even you appreciate it on the video. Oh, now look at him. He's not a baby anymore. He looked like a big boy now. It's really nice to see it also.
So my next question to you is, you mentioned that the follow-up rate has increased considerably because we had seen some, the follow-up appointments in numbers declining over the years, but with this, you really saw a big boost on families attending follow-up clinics. Do you see this continuing? Because you gave me a rate when we chatted a couple of months ago. What have you seen now that is 7 months into that?
So we're seeing the rate of increase is still like at least till preschool. We're seeing that steady increase. And I think this is where we see the highest number of follow-up rate and follow-up they show up. We see the decline with the school age. It was prior to COVID still there. And we thought it might pick up with virtual because the kids are not school and they're at home. We still have the same issue with the school age. And again, we're not sure, is it because at some point the family we give them the right tool and they're already don't have concerns, they're happy with what they have and they don't see the value of coming to us, which is totally fine. Or there's certain things that we have to look at why still our follow-up rate is not equal to what we see in the younger age, less than 3 years.
Right, just to clarify, because your follow-up clinic is a little bit different than others because you go much later in age than most of clinics in Canada.
Yes, so it's steady so far with all the kids still like starting school, and we still have the same kind of it is better with COVID, but it's still the same challenge with the school age kids.
Okay, so what are the issues that you've seen so far? Is there any technological issues? The families don't have access to Zoom, or they don't know how to use the technology, or any other issues that you've seen these last few months?
So we have a lot of challenges that family don't know how to access Zoom. So we created a document how to take you step with Zoom and how we do it. We even brought patients in person to show them Zoom, and then we will see it later. Phone and data, internet, if a lot of family don't have computers, so they use it on their phones with their own data. Challenges of the language barrier. So these are the main one that they're there, or they totally forget about our visit, because again, sometimes if you're not coming in person and you have too many things going on in your household and it's busy, you forget about the appointment, which simply we continue to reschedule. So these, we overcome a lot of these challenges.
Okay, so let's talk about giving difficult news for families, because you touch a little bit on that. And I feel like I received my son's diagnosis of quadriplegia cerebral palsy in person in the hospital by myself, and it was extremely hard because I went home and I didn't know what to do with it. Obviously, I went on YouTube and it was not a good idea what I saw. So now sometimes you have to deliver that news to families. online. So how is that going? What is your experience with that and the feedback you got from families?
So it's again, the feedback overall, it's working because we know kind of what's the challenges to anticipate from it, and we're trying to think about what the challenges could happen and try to avoid it as much as we can. Giving an unexpected news to the family about their child development, it's never going to be a pleasant experience, because again, like, this is a parent doesn't want to hear, and also us, like, it's very hard even for us to deliver. So this is where, like, we come and start, and we are with early identification and early intervention, because this is what will guarantee function. So what we really did is really point the things that, like, help the parent to see where the challenge is. So it's not only us talking about it, they are asking about it, and we kind of like start talking about what do we think that is going on with the child. And this is what we try to do with implanting the seeds. And not only just us with our surveillance, it's also by the coaching. Even the parent will identify what the things I can do and what the things I can't. And then seeing the child multiple times in their environment, addressing these, talking about what do we expect in this stage and where the child at. And then we start, like, formally talking about it. If we could see the child in person and have that in person because remember, we were going from the spring to the summer. So we were able to see family in a social distance platform around their home, in the park, and we were able to do that. I'm not sure how that's going to happen now with the winter. So we try to do that as much as we can in person. And then what we do, we follow it up with things. So if we're gonna talk about a formal diagnosis or a concern, we immediately follow it up with, what do we need to do now? This is what we need to do. This is the limitation with COVID and the restriction of services. I am gonna try to fill in the gap between the services as a team till the service start picking up. So I'm not leaving the parent alone in this. Because again, I'm giving a diagnosis, and so what? And what after?
Because a lot of those diagnoses are life-changing diagnoses for family.
Exactly. It's 100%. So then you're telling me you're giving me a diagnosis and tell me, oh, I'll see you later, bye. It doesn't work this way. So then we come heavily after a diagnosis with our amazing team and with the community provider to try to close the gap in the community till I am staying in, I am with you, this is what we're gonna do till the other service pick up. It might take months, it might take year, I am in. We also create binder. Instead of you going to YouTube and Google, can I give you a more informed, more functional, more kind of accurate information about these diagnoses? And so we created binders that basically look into what this diagnosis mean, how it can look like, what it can change across the lifespan. We connect you with the right, I would say, YouTube channel, parent provider, like groups and stuff, so you can listen from parent or like in that field. We try to provide all the funding services, all the paperwork that is really consuming, and a lot of parents do not remember or like wake up to do it after a year. We will take care of that. We sit down and we help with funding, with paperwork, with all these, and we do it with the team. I don't want you to go to your primary care provider. I don't want you to go anywhere. You're gonna come to us. And this is where amazing team and nursing doing a great job.
Oh, this is incredible.
So I hope we are. Again, did we have some time we did not do it right? Yes, we have times. But you know what? From feedback from the family, I would like to listen at these times, because then I can improve how I do it.
Absolutely. It will certainly be a learning progress as things
100%.
evolve and we begin, and you're pioneering this here, because I don't feel that families receive enough information once they receive the diagnosis. It's like, okay, we need to find around peer support, or where do we go for resources? So we are almost at the end of it, but there's two questions that I really want to ask you. As more clinics are moving to virtual space, how can you make those visits with families successful? Are there any tips that we can give to families how to prepare for those virtual visits?
Put your appointment in the calendar. That would be really helpful. Try to basically test your Zoom away, or like basically tell us what platform you're more comfortable with. If they have a specific concern or something that they want to come out of the visit, rather than going with, like, they have certain things, it will be really helpful if you tell me what do you want to come out from this visit. So I can basically customize the visit to what's the need, plus plus my agenda. And then if Zoom is not working with your family in particular, let us know. And then we can discuss with that individual family, what else can we do to make it successful, rather than you don't show up.
Absolutely. It's okay. One last message for families listening to us right now.
Paige, message to the family listening to us.
We got her message today as well.
Paige is in the room as well.
No, I don't think so. I think we want to help. We want feedback.
Yes, please feedback.
Absolutely.
We are here for you, and like, we really take pride of what we're doing, and we're always open for feedback.
Thank you. Such a wonderful work. Thank you so much, Dr. Banihani and Dr. Paige, because I know she's right at the back in your room. I really appreciate your time today, your commitment to the families, and to really empower the families to take the next step after they leave your clinic. So thank you so much.
Thank you. It's a pleasure ours to be part of your family.
Thank you.
Okay.
And thank all of you for joining us here today, and all of you who participate in the Preemie Health Talks throughout this week. We had 12 sessions, and this is the wrap for us, but we'll be back in November with Preemie Power Week. We have an amazing lineup of speakers. You can check on our website, CanadianPremies.org. Preemie Power Weeks start November 16th to November 20th. And I really want to thank Abby and Pampers for the ongoing support and to make this week happen for us. And our team at CPBF work really hard to make this week possible. And we have very exciting things happening in November in honor of Prematurity Awareness Month and World Prematurity Day on November 17th. A lot of monuments in Canada already confirmed they will be lit up in purple to honor our babies born early and the babies who didn't stay with us. So check on our website and you can go there, take pictures, and share with us all your pictures. Also on Sunday, we are launching a new collaboration with Pampers in honor of this beautiful month of November. And Pampers will be donating more than 200,000 diapers to support Canadian families and NICUs via the Canadian Premature Babies Foundation. And you can help support NICU's families across Canada too. And during the month of November and December, every time you use the hashtag Pampers for Preemies, Pampers will donate one extra diaper to Canadian NICUs through us. So this is very exciting. Stay tuned to our social media channels. We're going to be sharing more information from Sunday. And thank you all of you who join us here. And just a reminder that CPBF is a registered charity, and 100% of all donations received during this week we go to our educational programs for families. To donate, please go to CanadianPremies.org. It takes only 3 minutes of your time. And we make a huge difference in the lives of the families that we serve. And thank you, and I stay well, and I hope I see you all in November.